Hello, everyone. Our topic today is management of rib fracture pain. The objectives of the presentation are the following: the anatomy, prevalence, pathophysiology, flail chest, ventilatory management, management of acute and chronic pain, and then we'll end with our usual key learning points. Anatomy of the chest wall. Of course, the chest wall is surrounded by very important muscles like the pectoralis major, serratus anterior, latissimus dorsi, trapezius from behind. The back, upper back and lower back, as you can see, it has 4 layers. And that's why the back muscles are one of the most important and strongest muscles in the body. As you can see, first layer, you have the trapezius, latissimus dorsi. Second layer is the rhomboidus major and minor above, and you have also the teres major muscle. Layer 3 is the levator scapulae and the serratus posterior. Layer 4 is the splenius cervicis and the erecto spiny muscle. All these muscles have an implication to our presentation. That's why I'm giving you some sort of an idea about it. Okay, this is a cross section. As you can see here, the upper left, you have the rib, and then you have the intercostal groove. You have the vein, the artery, and the nerve below the rib. By the way, these structures are not necessarily below the rib directly. They could be below the rib, they could be in the middle of the space. So there is some variation there. And this is, if you look on the on this cross section, you will see, the branches of the intercostal nerves. Starting from the gray and white rami, communicans. Branch 3 is dorsal rami. Branch 4 is the lateral cutaneous nerve. And branch 5 is the anterior cutaneous branch. All of these have implications in our discussion. Prevalence. So, trauma is the major cause of morbidity and mortality worldwide, and the leading cause of death in the first 4 decades of life. Rib fractures are very common and are detected in at least 10% of all injured patients, the majority of which are as a consequence of a blunt thoracic trauma, 75%, with road traffic collisions being the main cause. The remaining 25% are due to penetrating injuries. Rib fractures are associated with significant morbidity, with patients frequently requiring admission to the intensive care unit, and the mortality rate could be as high as 33%. And all of these data is from the British Journal Education Journal, Volume 16. Pathophysiology. This morbidity and mortality is associated with rib fracture is basically caused by 3 main problems. Number 1, hypoventilation. Number 2 is impaired gas exchange. And number 3 is altered breathing mechanics. Again, from the British Journal of Anesthesia Education. Age, the elderly are particularly susceptible to rib fractures and associated complications, with pneumonia rates as high as 31%. Ribs fracture are uh, more easily and are often the result of only moderate trauma. So why elderly? Well, this is a consequence of osteoporosis, cartilage degeneration, and reduced elasticity. Respiratory mechanics are usually affected due to reduced muscle mass and a weakened diaphragm and intercostal muscles, along with loss of alveoli. These changes culminate in reduced lung volume, decreased lung function, and impaired gas exchange with poor respiratory function. All of these alterations, along with other comorbidities, make the elderly patients with rib fracture at increased risk of hypoventilation, atelectasis, pneumonia, and subsequent ventilation. Numbers of ribs fracture. The number of ribs fractures correlates with the severity of the injury, and together with the age, they are the most important determinants of morbidity and mortality. 4 or more fractured ribs are associated with higher mortality rates, and 7 or more have a mortality of 29%. The presence of a flail chest has a reported mortality of 33%, since the paradoxical chest movement further inhibits effective ventilation. Flail chest, the breaking of 2 or more ribs in 2 or more places. That's the definition of flail chest. In the presence of a flail segment, the generation of a negative intrapleural pressure produces paradoxical movement of the flail, causing it to move inward while the rest of the rib cage moves outward. This means that the underlying lung doesn't expand, and as a result, the tidal volume decreases, and this has been demonstrated clinically, although an increase of the respiratory rate means that PCO2 remains normal. This inefficient breathing results in a higher oxygen consumption and has been shown to reduce the arterial oxygen tension. This is a picture explaining what does flail chest means. As you can see, in inspiration, the broken segment goes inside, okay? And in expiration, it goes outside. But it's not moving, in coordination with the rest of the chest wall. And this will lead to inefficient breathing. Chronic pain and disability are significant contributors to diminished quality of life after trauma. Little is known about the prevalence of chronic pain and disability after rib fractures, but a recent prospective follow-up of 203 patients with rib fractures found a prevalence of chronic pain of 22% and disability of 53%. Only acute pain intensity and bilateral fractures predicted the disability, with operative fixation force vital capacity at 12 months is greater. More people return to work and the incidence of chronic pain is reduced. So I want to just, bring your attention to a couple of things. So basically, the prognostication of rib fracture depends on 2 factors. Number 1 is the age. Number 2 is the number of the ribs fracture. Okay? Now, as far as chronic pain, also the prognosis is relies on two factors: the acute pain intensity and if you're having bilateral fractures or not. Nowadays, they do surgical fixation of these ribs, and this have been shown to actually um, have a positive effect on these folks. And these patients, they had the chance to go back to work earlier. And the incidence of chronic pain reduced with the operative fixation. Clinical picture. So I had this rib fracture, maybe 2, 3 years ago. It wasn't really a major one, but I fell and I had a blunt trauma. And basically, this is exact picture, clinical picture I had. You will have dyspnea, you will have localized pain and tenderness, you will have pain that increases with cough, movement, and deep breathing. Um, Deformity, I didn't have deformity. Um, Instability, crepitus, ecchymosis, pneumothorax. I was fortunate enough I didn't have these, problems. The crepitus and the ecchymosis, pneumothorax, and hemothorax. Um, this is the rib fracture score that we talked about. And plus the age, remember, these are important prognostic factors, in this rib fracture issue here that we talked about. Breaks is the total number of the fractures to the ribs and not the number of the ribs fracture. So you multiply the number, you know, it's not just the number of ribs fractured, it's the number of the fractures to the ribs. For sides, unilateral scores is 1 and bilateral is 2. So for example, 2 fractures in one rib is 2. For the sides, if it's bilateral, then it's 2. If it's unilateral, 1. Age is also factored into the equation. Okay? Um, with different aging groups scored between 0 to 4. So we have the rib fracture score, breaks times size plus age factor. Refer patients to acute pain service if the rib fracture score is above 7. So the whole idea here, why we're using this rib fracture score, is if your score is above 7, you need to call the acute pain service. That's the importance of the rib fracture score. Ventilatory management of patients with rib fracture begins with supplementary oxygen, which should be humidified to loosen up the secretions and help with the sputum clearance. Nebulized saline may also help reduce the sputum retention. CPAP could be useful. Positive airway pressure will lead to reduced atelectasis and reduced intrapulmonary shunt, and will reduce the paradoxical movement of the flail segment if present. However, it can be uncomfortable for the patient and may make expectoration more difficult. Ultimately, if other measures fail, sedation and invasive ventilation may be necessary. This is extremely undesirable and should be avoided where possible in patients without other injuries. Pain management, therefore, plays a key role in managing these patients. Once ventilated, early weaning from a ventilator is paramount. This picture shows you the first aid, kind of therapies that we do for fracture rib. The whole idea is to stabilize this fractured segment. Once you stabilize it, your other lung will be, working well, and you will not have pain. You will not have all the complications that happens with the rib fracture pain. So remember, with the first aid, we need to stabilize the fractured segment. Also, incentive spirometry is very useful in these situations to help with the atelectasis. Nebulized saline to loosen up the secretions. Analgesia for rib fractures. This is the part that, as anesthesiologists, we're involved with. The associated pain is notoriously difficult to manage, but effective analgesia starts promptly, uh, prevents hypoventilation, and enables deep breathing, adequate coughing with clearance of pulmonary secretions, and compliance with chest physiotherapy. Overall, this reduces the secondary pulmonary complications such as atelectasis, pneumonia, respiratory failure, and the need for respiratory support. Patients presenting to the ER after a blunt trauma may require urgent intervention, including intubation and ventilation, but others may show little or no respiratory compromise. However, pulmonary complications often uh, only become evident 48 to 72 hours after the injury. It is therefore imperative that effective analgesia is started promptly, preferably in the emergency department upon admission, not just for analgesia and patient comfort, but also to try and prevent the complication that that happens after the subsequent days. Opioids were previously the mainstay of treatment, but with significant side effects, including respiratory depression, depressed cough reflex, and delirium. Multimodal analgesia now is more commonly used, which incorporates regional nerve blocks and thoracic epidural. I remember I received, Tylenol number 3 that has codeine in it, when I had this rib fracture. But mine was really minor compared to other type of fractures. But really, I went through the experience, and it took some time until the pain got better. And this really led me to present this lecture because I felt like, this is something can happen to anyone. So this is kind of an algorithm from the British Journal of Anesthesia here. As you can see, step 1 is regular paracetamol, then and regular codeine, and then if it's not controlled, you give IV morphine, and then you can, if it doesn't work, you can try a PCA. And then step 4, a complex regional anesthesia. You can do blocks like the serratus anterior block. We're going to talk about it. Paravertebral block, thoracic epidural. Consider rib fixation, and contact the pain team. And this is the rib fracture score. Very important, okay, to calculate this rib fracture score, because if you're above 7, you need to send the patient to the acute pain service. Otherwise, you can handle it as a primary physician or as an internist or as a surgeon. You can handle it by yourself. But if you have a rib fracture score above 7, you need to involve the acute pain service. Okay, so anesthetic pain interventions. We'll start with the simple analgesics in step 1, and that's what happened to me. And then, if it doesn't do the job, then do IV opioids / PCA. Step three is regional anesthetic techniques, and we're gonna, give you a full detailed explanation about these different techniques. And step four is the operative part, which, as I mentioned earlier, in some situations, these are very important, essential for the patient, to resume his, work and all that stuff, especially if it's a bilateral fracture that's associated with severe acute pain. Regional anesthetic techniques. So this is basically some of these blocks like intercostal, epidural, erectospiny. I want to mention something, okay, and I want to really implant this concept. We have blocks that are central, and we have blocks that are peripheral. So the more central you are, like thoracic epidural, for example, all right, the better analgesia you will get, but the more complications you might encounter. And also, the more central you are, it's difficult to, justify doing this procedure in patients that's anticoagulated, and also these patients that are having spinal cord injury. Okay, so everything has its pros and cons. While if you're doing peripheral blocks like serratus block or erectospiny or whatever, these blocks they can be done in anticoagulated patients and patients with spinal cord injuries or suspected spinal cord injuries, and also, they have less side effects and less complications. However, the analgesia is not the same. You cannot compare a serratus block to a thoracic epidural as far as the analgesia. So it's a kind of balance, you know. You get less complications and less analgesia with the peripheral blocks. And I put it in a table here. This kind of explain to you, the different techniques. So there is a tendency, okay? There is a tendency to go peripheral. I mean, it makes more sense, right? Why should I, basically get into, for example, epidural hematoma, thoracic epidural hematoma from a thoracic epidural block? I mean, it doesn't make any sense. If I have a substitute, maybe less quality, but at least, we have, better side effect profile. Thoracic epidural analgesia, it's the gold standard. Okay, I mean nobody can argue about this. And patients that have higher rib fractures, multi-level or bilateral fractures, flail chest, intercostal drains, and functional respiratory compromise secondary to pain benefit most from epidural. So I would do epidurals, thoracic epidural, in patients that have higher rib fracture score, patients that, a more extensive injuries than, localized type of fracture. As I said, if I have just a localized area, it's better to deal with it with one of these nice peripheral blocks that we talked about, the serratus, the erectospiny, whatever. But if it's something that's extensive, patients with flail chest have intercostal drains and have functional respiratory compromise, then thoracic epidural will make sense. And as we said, the thoracic epidural is the gold standard. Multiple retrospective reviews and prospective trials have demonstrated improved pulmonary function. including tidal volume and maximal inspiratory force, enhanced analgesia, with overall better clinical outcomes when compared with treatment with systemic opioids. The improved pulmonary function reduces the incidence of pneumonia, number of ventilator days, mortality, especially with sustaining 5 or more rib fractures. This is basically how you do the thoracic epidural. Now, for me, you can do it landmark technique. You can get the help with some ultrasound guidance. But as far as I'm concerned, since I do most of my procedures under C-arm, I would proceed with doing this thoracic epidural if there's no contraindication under X-ray guidance, because it makes it much easier to do it, okay? Because of the angle of the spine. You have to be, you have to do a lot of these, okay? So you can go with the proper angle. So when you do it on the C-arm, it makes your job much easier. Paravertebral blocks, injection of local anesthetic in the thoracic paravertebral space produces unilateral sensory, motor, and sympathetic blocks. The paravertebral space communicates with the epidural space medially and the intercostal laterally, but with adequate volume, the majority spreads caudally and cranially, covering at least 5 sensory dermatomes. Paravertebral blocks can lead to inadvertent vascular puncture in 6.8%, hypotension 4%, epidural or intrathecal spread 1%, pleural puncture 0.8%, and pneumothorax is 0.5%. This is the paravertebral block, and this is the green one here is the paravertebral space. Okay, so you go until you hit the transverse process, and then you go above it, and basically you'll be there in this paravertebral space area. As you can see, it communicates up and down, communicates medially and laterally, so in 4 directions. So you have to be careful with the volume of local anesthetics you're injecting, because you can produce hypotension. This one can be done under ultrasound guidance, as you see in this picture, and you can do it landmark technique as well, and you can do it under X-ray. So you have 3 available methods, depending on your resources. As you can see in this one, using the landmark technique, he hit the transverse process and he went above it until he punctured this a ligament, costotransverse ligament, that gives you like a pop, like an epidural pop. And then you will get loss of resistance. This is the paravertebral block under ultrasound guidance here. And this is the ligament I just mentioned. As you see, you're very near to the pleura. So you gotta be careful. Once you get the pop, you need to inject your medication. This is a picture on the C-arm guidance. Very nice picture. Again, it goes up and down, goes medial lateral. Okay, next to this peripheral block, there's the erector spine. Of course, the paravertebral has less complications than the thoracic epidural. But as you go more peripheral, you will have less and less. So this one is one of the new blocks, sort of, the erector spinae plane block. And it's extremely safe. And you can, actually do it blindly, or you can do it under ultrasound, which will help a lot. And even you can do it under X-ray guidance. The first report of successful use of this procedure was back in 2016. So it's even less than 10 years. This block has been reported to have been used successfully in multitude of procedures, including thoracotomies, percutaneous nephrolithotomies, ventral hernial repairs, and even lumbar fusions. Erectospinal plane block. And if you look at it, it's first of all, it's done outside. We don't go, once you hit the transverse process, you don't go deep. You just inject in this compartment of the erector spinae. Remember the erector spinae from the earlier pictures I showed you, it's in the fourth deepest layer of these back muscles. And look at the distribution of the local here, after you inject. It goes up and down. Some of it goes to, epidural space, some of it to the intercostal, but really it's kind of pretty safe, even compared to the paravertebral blocks. As you can see, you can do it ultrasound guided, and all you need to do is hit the transverse process, come back and inject your local. Erectospinal plane block. Erectospinal plane block under X-ray, and in this case, this patient received the catheter. So you can put a catheter. Same thing, of course, with paravertebral and thoracic epidural. All of these, you can run a continuous infusion. And this is basically the pattern of the block. In fact, it spreads even to the other side. Some of it, not complete, but some of the local will go to the other side as well. Okay, another extremely important one, the serratus anterior plane block. Please remember this block, guys. Okay, this is a really super easy, super safe block that can save your day here. This one was first described by Blanco and colleagues, and the block is performed with patient in the supine position, and the arm is abducted using an ultrasound probe here of between 6 and 13 megahertz. Place the probe in the sagittal plane. Identify the fifth rib in the mid-axillary line. Latissimus dorsi and serratus anterior muscles are now easily identifiable overlying the fifth rib. The planes can be found between the depth of 1 to 2 centimeters from the skin, with the thoracodorsal artery passing in the superficial plane to the serratus anterior. Watch for the thoracodorsal artery. It is a useful landmark. Serratus anterior plane block, technically easy, performed with patient spine So this is an advantage. You don't have to position in any odd positioning here. Suitable for rib fracture patients with associated spinal trauma or head injuries. Uh, can be inserted in anticoagulated patients. Midline sparing. It doesn't cover the anterior cutaneous nerve. So remember this part. So if you're having pain in the anterior part of your chest wall, this will not, help you out. Serratus anterior plane block, and look at the distribution of the block. The only area that's spared is basically the anterior part. And this one, we have another type of block that we can use for that. If the pain is central, like midline. There are two types of, a serratus anterior pain block. There's one, we call it the superficial serratus anterior plane block. And in this one, you injecting the local, underneath the latissimus dorsi. Okay. And the other one is under the serratus muscle. All right. It doesn't matter which one you would proceed with. Both of them, they give the same results. Of course, the superficial could be more safer because of staying away from the ribs. But you can do the deep or the superficial. All right. Intercostal blocks. This was in old days the standard, guys. We used to do this intercostal, everywhere. And right now it's getting, out of favor because of the appearance of these new blocks like the serratus anterior plane block and the erector spiny plane block. It can provide effective analgesia, reducing the morbidity and the length of stay. Risk of local anesthetic toxicity. That's the major complication. Contrary to a lots of belief that the pneumothorax, it's not really common with the intercostal blocks. The reason is you're somewhat far away from the pleura. Once once you hit the rib and you just slide the needle below the rib, okay, you can inject your medications, and it's kind of far away from the pleura. And I want to say something. I mean, to produce pneumothorax, you have to really puncture the lung because the air will come from inside, not from outside. Okay, and once you puncture the lung, the air will escape from the lungs to the pleural sac, and you start to develop pneumothorax because it will be entrapped; it will not come back. So the likelihood of getting a pneumothorax with intercostal is really small, less than 0.5%. But the commonest complication is the toxicity, local anesthetic toxicity, because it's a highly vascular space. You can do it, as I said, with ultrasound. You can do it landmark technique. I don't like to use the word blind technique, guys. Okay, I'm sorry I just have to tell you this part here because it irritates me, but sometimes I say it myself, Uh, don't say blind technique, say landmark technique, please. So landmark technique, you can do it ultrasound guided. You can do it with under C-arm, like in this picture here. You know, he's targeting the lower aspect of the rib, and then he got a little bent in his needle. Once he reached the rib, he will just go beneath the rib, and then he will inject the medications. By the way, I mean, we do this in the prone position. You can do it in the sitting position. I do it in the prone position, 5 to 7 centimeters from midline. Okay. Some of the medicine will get into the epidural sac, by the way. All right, because even if it's 5 centimeters, it still can go to the epidural sac. Then we have PEC 1 and PEC 2 blocks, and the serratus plane blocks are peripheral nerve blocks alternative to the paravertebral, providing both surgical anesthesia and postoperative analgesia for breast surgery. So PEC 1 and 2 and the serratus blocks are very useful in breast surgery. In old days, I remember, like back in the 2000s, and I mean, we were putting thoracic epidurals or doing paravertebral blocks for breast surgeries. As you know, these blocks help a lot, with these patients that have major breast surgical procedures from getting chronic pain and stuff like that. Nowadays, this has been substituted to the more simpler peripheral blocks that we just talked about, like the serratus plane block, and now we have another addition, which is PEC 1 and 2. All right. As far as the PEC 1 and 2 blocks, you need to look for the pectoral branch of thoracoacromial artery in PEC 1 block. So when you do ultrasound guided procedures, you need to really think about structure that could help you find out where you put your needle at. And usually this structure is a vessel. So these are basically PEC 1 and 2. Blocks. The first one, the PEC 1, is between the PEC major and PEC minor. And the PEC 2 is beneath the PEC minor. And this is basically the distribution of the local, in PEC 1 and 2. Again, one is between PEC major and PEC minor, and the PEC 2 is below PEC minor. Parasternal intercostal blocks. Parasternal intercostal blocks basically blocks the anterior cutaneous intercostal nerves and is used as an adjuvant for pain management post-cardiac surgery. This modality is highly effective in patients experiencing sternal wound pain following cardiac surgery or trauma. Remember, we said these blocks, unfortunately, they do this sparing in the midline. So they came out with a block that can target this anterior cutaneous intercostal nerves. For example, if you had a patient with had cardiac surgery and they opened up the sternum, so this would be a very nice block to do before the procedure. This way, you will not have a lot of pain from the surgical side. Parasternal block. Again, as you can see, you put your needle in the space between the pec major and the internal intercostal. 2 centimeters from the sternum. Again, pec major, between pec major and internal intercostal. Parasternal intercostal block. Look at, again, we look at the vessels here, guys, okay? Okay, we'll end our presentation with the surgical fixation. And this procedure actually is gaining momentum. Of course, this is done by a thoracic surgeon. The rib fracture fixation has made a resurgence, with evidence suggesting it's beneficial for a certain group of patients. Intubated patients with flail chest, respiratory failure, and prolonged ventilation, or non-intubated patients with a flail with deteriorating pulmonary function. So we reserve it to extensive cases, okay, like intubated patients or non-intubated with a flail chest. All right, this is not like your first thing to do. This is your like last resort, or if you're having an extensive injury. The aim is to stabilize the chest to restore pulmonary mechanics and reduce pain. Remember, guys, you know, when you fix any bone or fuse it, uh, it basically allow this segment not to move. And this, once you do so, this pain is much better controlled because the pain comes from the movement itself. Other indications: rib fractures, refractory conventional pain management, and rib fracture non-union. Look at the surgery. Management of chronic pain. We have pharmacologic, physiotherapy, interventional, regional techniques described before. And there are a couple of techniques that I want to talk about, like the pulse radiofrequency, which we can do for either for the intercostal nerves or the dorsal root ganglion, and cryoneurolysis and surgical fixation. And we described all, you know, the techniques in the presentation. We just left with these two: the pulse radiofrequency and the cryoneurolysis. So pulse radiofrequency is a kind of a radio frequency that comes in a pulse form, and it's not, you know, damaging to the nerves because the temperature is lower than the conventional radio frequency. It's less than 42 degrees. Okay, so it does help disrupting the pain in the C fibers, but it doesn't damage the nerve. And damaging the nerve can lead to a sequelae that undesirable, like for example, you know, especially in the intercostal block area, intercostal nerve. I mean, you can damage the motor nerves going to the abdomen, and this can lead to a hernia because you're gonna weaken up the muscles, you know, going into the abdomen here. So also can lead to neuroma formation, all right, and can lead to something called anesthesia dolorosa or deafferentation pain. So pulse radiofrequency is really very safe. You can also apply it to the dorsal root ganglion. So you have two choices: either you know, the intercostal nerve, like it will exactly look like an intercostal block. or a dorsal root ganglion, which will, I mean, almost like a transforaminal epidural. Here in the dorsal root ganglion here, as you can see. There's also another emerging, gadget here is the cryoneurolysis. Cryoneurolysis has been there forever. However, recently they came out with new probes that are much smaller in size. We used to use like 14 gauge and 16 gauge probes. And this was the most important limiting factor for these cryoneurolysis. Nowadays, we have actually, smaller probes. Now, and this made it, more practical to do. The cryoneurolysis works through a phenomena called Joule-Thomson effect. And what is Joule-Thomson effect in a nutshell here is basically decompressing the gas. Usually we use CO2 or nitrous, and at the tip of the probe here will create a reduction in temperature and development of an ice ball. And this is basically cryoneurolysis in two words. The nice thing about cryoneurolysis, you can see the ice ball. Okay, this is really important. It looks like black in the ultrasound if you're doing it on the ultrasound guidance. Look at the ice ball. Now, cryoneurolysis, this is the anatomy of the nerves. As you know, we have basically the fascicles, we have the blood vessels, we have the epineurium, we have the endoneurium, and we have the perineurium. And again, you will have the nerve that's covered with myelin sheath, and inside you have an axon. So according to Sunderland, we have different, degrees of nerve damage. We have first degree, second degree, third, fourth, and then fifth degree. Okay. Now with cryoneurolysis, you can have up to fourth degree, but it's first and second degree neuropraxia. This is reversible. Second degree is axontomesis. And third and fourth degree, you have neurotomesis, loss of continuity, some of the loss of continuity of epineurium and perineurium and endoneurium may or may not be disrupted. The fifth degree cannot be achievable with cryoneurolysis. And this is the nice thing about cryoneurolysis, is that after some time, you probably gonna gain back like your motor function if you're working in a mixed nerve. So it's really an alternative to pulse radio frequency. Good alternative. Basically, we use a machine called Cryo-S Painless. And basically, Cryo-S Painless uses CO2 or nitrous oxide. At a minus 89, and this one minus 78. Cryo-S Painless. And this is basically, I put it in a table here, the difference between conventional radio frequency, pulsed radio frequency, and cryoneurolysis. Um, Again, I want to focus on cryoneurolysis. It's unlike conventional radio frequency. It causes reversible damage. It works by the virtue of Joule-Thomson effect using CO2 or nitrous oxide. It's virtually painless. It causes neuropraxia and neurotmesis. It's useful in neuropathic pain. Same indications as conventional radio frequency, water-cooled radio frequency, and pulse radio frequency. So the cryoneurolysis is the joker right now. It's the one that really covers all types of radio frequencies. Okay, but of course it works the opposite way by freezing the nerves, and not burning the nerves. Okay, pulsed radio frequency, unlike conventional radio frequency, works by electromagnetic field developed at the tip of the probe. Also virtually painless, no signs of destruction, useful in neuropathic pain, useful in patients that have mixed nerves like greater occipital, suprascapular, dorsal root ganglion, intercostal nerve blocks. How about the conventional radio frequency? The mechanism of lesion of degeneration is generated, which is more predictable and controllable than DC generators. It's painful. It can lead to neural destruction. It can lead to neuroma. It can lead to deafferentation pain. The water-cooled radio frequency is a variation of conventional radio frequency, and it has a bigger size lesion, and thus it's useful in genicular blocks and sacroiliac denervation. So this wrapped it up. Again, this is the machine for the cryo. And I again want to tell you about the Sunderland. With the cryo, we usually do the first or second degree only lesions, so it becomes reversible sort of. We don't usually use less than minus 140 here. So we don't reach this stage. We always stick with this stage because this gives you a reversible lesion with cryoablation. And this fifth degree is not possible with cryoneurolysis. Okay. Cryoneurolysis versus conventional radiofrequency. Cryoneurolysis of peripheral nerves, method of action called -60 to -80. Remember, from the Sunderland classification, this will lead only to a neuropraxia or exonthomesis, which are reversible. Okay? With heat between 60 and 90, electrode diameter of 1.3 to 4. This one is 0.25 to 10. Treatment length is 120 to 180 seconds. So basically 2 to 3 minutes. And this conventional radio frequency, somewhere between 60 to 90 seconds, so between 1.5 minutes. The lesion is symmetrical in the cryoneurolysis. The conventional is elliptical. And the introducer size, as you can see, starts from 12. I mean, we're not using this anymore, but in old days we used to have this 12 and 14 gauge. I remember I used to do intercostal blocks with it. And it was very effective, but I mean, it's kind of scary, sticking a needle with that size in the intercostal space. So, of course, you have to put enough local and make sure the patient is, monitored after the procedure for pneumothorax. Functional limitations, larger introducers, recent probes, as we said, are thin, length of neurolysis, poor neurolysis in poorly perfused areas near the bone. Length of neurolysis, ease of use. I mean, all of these are the problem with the cryoneurolysis is availability. It's not really as commonly used as conventional radiofrequency. Cryoneurolysis is safe, and the cost is a little bit more expensive because of its availability here. Key learning points. Traumatic rib fractures are common, resulting from significant forces impacting the chest and are associated with significant morbidity and mortality. Respiratory complications, including pneumonia, are common, occurring up to 31% of the patients. Prompt multimodal analgesia, incorporating regional anesthesia, IV opioids, and oral adjuncts are essential to reduce complications. Operative fixation is indicated in some situations. Thank you.